Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
There is much cause for optimism in the world of prostate cancer with new research both current and on the horizon. During the next hour, we have experts answering questions about prostate cancers from screenings to diagnosis to treatments. And stay with us in some questions that you'd like to ask us this evening. Give us a call at 881-0013. We are also streaming this live on YouTube. You just have to put into the search engine El Paso Physician. This evening's program is underwritten by Rio Grande Urology, and we also want to thank the Texas Tech Paulo Foster School of Medicine for providing our medical students to man our phones. And tonight we have Mustafa Zybek, and he is a second year. And I always like it because it seems like the first years are the ones that always get it. But this is September into his second year, so it's kind of like a first year, but he's graduated, so it's kind of nice. So throw your questions his way. He will be answering the phones and then sending them our way. This is a live program, which is super helpful because sometimes the topics that we cover, it's nice if you get to answer the questions and have the questions be anonymous. We also want to say a huge thank you to the El Paso County Medical Society, who's been doing this show for over 24 years now. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. We have two veterans with us this evening, and I really enjoy just listening to their conversations prior to us getting on the air, and they're talking about clinical trials and just stuff that they do all day, every day that you may or may not be interested in, but we may touch base on some of these things. But we have Dr. Daniel Vogelweed. It used to be back in the days we always had the three bearded men on during the prostate cancer show, and so thank you for having a beard too, because you get to carry on that tradition. But Dr. Vogelweed is a urologist, and Dr. Travis Mendel is a radiation oncologist. So we have all kinds of things that we're going to talk about. We're looking at male issues today for the most part. Even though you're a urologist, we're going to try to keep things on the male spectrum when it comes to that. And Dr. Vogelweed, I feel like I've been doing this 24 years. I feel like you've been here one of the first or second or third shows that we've ever done together. So I appreciate you being here.
I thought it was only about 3 years.
Well, maybe 4.
Okay.
We can give ourselves a little bit of credit. We'll do it 4 years. But as a urologist, again, I know it covers so many things, but we're talking about it's Prostate Cancer Awareness Month. And how is it that you can describe your job when it comes to this particular program? I know you got a lot of other things going on, but when it comes to prostate cancer.
Well, my job in particular at this stage of the game is treating patients with advanced prostate cancer. In other words, patients that are no longer curable. But we have so many things that we can do for these patients to prolong their survival and give them longer survival with better quality of life than they would have otherwise if the disease just progresses.
And the better quality of life, again, we were talking prior to the show, there's some things that Dr. Mendel is going to talk about regarding treatment, and with prostate cancer and other cancers, radiation, there's all kinds of tissues around the radiation. But we're going to talk about some new things that are current and some things are on the horizon as well. But to describe what you do all day, every day, feel free to take it from there.
Sure. So radiation oncologists, we basically focus on cancer patients for the most part. When you are diagnosed with, specifically a solid tumor, you're going to have 3 members of your team. You're going to have a surgeon, which is the urologist role in prostate cancer. You're going to have a radiation oncologist, who is either going to treat you postoperatively or definitively with radiation, and then a lot of times you'll have a medical oncologist who will prescribe any different types of systemic therapy, chemotherapy, immunotherapy. A lot of times the urologist will prescribe the hormone therapy.
Okay.
But for me, what we do is almost like a non-invasive surgery, where we go in with the radiation and kind of pinpoint the areas where the tumor is or the cancer cells are hiding.
And just over the last 5 years, I've been, again, 20 years ago, prostate cancer was so specific because you had to get to a very, very small area, and then there's a lot of area around it that kind of got schnackled a little bit. So that is something that I'd like to talk about a lot this evening of how the targets come into play. Gracie, we have Gracie Torres in the back, who is a rock star and able to get some of these slides up. And Gracie, if we can put up slide number 2, and Dr. Vogelweed, I'd like for you to go over just the anatomy of where the prostate is exactly. For those people who don't know, it's kind of nice to see exactly what functions, where, how, why. And if you could in here, and this is always the $10 million questions, it's screenings, right? So while looking at this, we can talk about the digital rectal exam that nobody likes to talk about, but why is it there? And we can see what we're looking at. And then also the PSAs that we're doing in the world of screenings. And I know there's recommendations that change all the time, but if you can take it away here.
Well, there you can see on the image on the left-hand side. I don't even know what that thing is on the right-hand side. That's
That's a Dr. Mendel thing.
Mendel thing.
You get to do the, yeah,
But
exactly.
In that picture on the left, you can actually see the prostate and the seminal vesicles that are outlined, which is the part that he treats. It sits right underneath the bladder. It sits just in front of the rectum. And anteriorly, you have the symphysis, the pubic symphysis, which is a bone that you can feel when you're feeling down below your belly button, the hard spot above the penis. And that's basically where it sits. What was the second part of that?
The second part of it was just let's talk about the function of the prostate. With urology, there are large prostates, and I know we're talking about cancer this evening, but the function of the prostate, and also in the world of urination, when men have enlarged prostates, and I'd like to cover that a little bit before we get into the cancer, because it's also part of what people are looking at home. It's like, okay, so if I have an enlarged prostate, what does that mean? Does that mean I'm going to get cancer? Does it mean I have cancer?
It's not.
Yeah, exactly. I'd like to go into some of that explanation.
No, it's not related to cancer. Naturally, as we get older, our prostates get a little bit bigger. And some people, they get much larger, and some people, they don't get, just a little bit larger. And then size doesn't matter. And the reason I say that is, generally speaking, as the prostate gets larger, you have more possibilities of having symptoms of an enlarged prostate, which is basically frequency, getting up multiple times at night, a weak stream, dribbling when you get done. But you can have a small prostate and have those symptoms, or you can have a large prostate and not have any symptoms at all. But generally speaking, the larger it is, the more likely it is you're going to have symptoms.
Okay.
I would add something.
Yes, Dr.
that
Mendel?
a lot of times in my clinic, patients come in and they ask me, like, how do I have cancer? I feel fine.
Right.
And this is one of those cancers that really does not have symptoms. Like prostate cancer is pretty rare for patients nowadays with screening and everything to actually have symptoms coming in.
Right.
And so it's important to understand that, because patients associate cancer with death, pain, and they don't have any of these issues. And so they're kind of confused a lot of times when they come to talk to me. So.
And you were great, because you reminded me of the second question I asked Dr. Vogelweed, which I forgot too, screenings. So the reason it's so important is that there isn't something that you feel often, if at all. So what are the current screening guidelines, and what do you tell your patients?
That's a very, very important question, because the United States Preventing Task Force for Prostate Cancer came out in 2012 and said you shouldn't screen anybody.
You shouldn't screen anybody.
They came out and they said exactly that. Okay, and so what it did is it caused a lot of primary care physicians to no longer order the PSA. And what that caused is a switch in the pendulum, whereas we were detecting, and unfortunately sometimes over-treating prostate cancers, to having patients come on the other side and they already have advanced disease by the time we pick it up. If you look at labs, you go to Path Lab, you go to LabCorp, you go to whatever hospital you want, and you look for the normal value of PSA, they usually say it's from 0 to 4, okay?
Right.
That is not correct.
Okay, let's talk about this then.
Okay.
Right.
David Crawford, who is one of the well-known physicians with a lot of clinical research experience in prostate cancer, came out with a suggestion that anybody that has a PSA above 1.5 should probably be referred and evaluated by a urologist. And they can do additional testing to determine whether or not anything further needs to be done. Personally, I've picked up prostate cancers with PSAs of 1.6, 1.7 with additional testing. Generally speaking, if your PSA is less than 1, you probably don't need to be checked again for 5 years. I'm just talking about the blood test, okay? We're not getting into family history or anything like that. You should initially have a PSA done and a rectal examination done when you turn 50.
Right.
Unless there's a family history of prostate cancer or you're black. Black males usually should be screened by the age of 40, 45. If you have a family history, screen at 40, 45.
So, and I feel like I should know this, when women are a little bit different. I feel like women go in annually for all their girly checkups, all the female stuff. And then in there, you usually have your blood test taken and you have all these different vials that go into whatever. If there is a male who's going to get all of his, I'm 50 years old, I want to get everything checked now, is the PSA blood exam part of the exam that kind of goes into all the other blood work? How does that work? Is it, I would just imagine
It should.
Okay, but
And
it's
not necessarily done.
Okay.
You know, and you know, physicians out there need to know two things. One, you should do the screening. Two, you don't have to, you know, if you do the screening and it comes back, you know, with a PSA of 0.8,
Then there's no
you don't
point.
need to check it
Right.
again for 5 years.
Right.
You know, and so not every, and most patients don't have high PSAs. The other question you're going to ask is, what's the cutoff? You know, when do you
Right.
stop? When do you stop checking? Well, that depends. Again, it used to be the AUA, American Urological Association, recommend that after the age of 70, you don't need to screen anybody. But we've got healthy 75-year-olds that are going to live
yeah.
to be 85 or 90, and I'm in that group.
80 is the new 60. I really
Yeah.
feel that 80 is the new 60. I feel like we are all living beautifully and healthily a lot longer now.
And so, in my opinion, if you are a 70-year-old or 75-year-old and you think that patient has a good 10 years ahead of them, they should be screened.
Absolutely, absolutely. And that's a cause for another day, but that should be something that is advocated, that is a, I just automatically thought it was part of the blood screening. Because 50, I feel like 50 is the age you get colon, you get prostate cancer, you get all these screenings done, and it should be thrown in together in one lump sum. If not, we're gonna start talking about that. Dr. Mendel, so if we can go back to slide number 2 that we had up earlier, what I like when you said, I don't know what that other thing is on the other side. Dr. Mendel, if we can talk about the radiation therapy and side effects, again, it's slide number 2. What are we looking at? What is that pretty piece of artwork right there that's green and blue?
It's a colored rush chart.
Yes, it's a painting I gave Dr. Volgowitz last year.
There you go, I like it. You get a frame.
Basically, this is a slice through a CT scan, and that's what we use to plan the radiation treatments. So I guess I'll just kind of explain this basically how I would explain it to a patient. So,
Okay.
So essentially what we're doing is using radiation beams to focus on the prostate like a lens. And the way I like to think about it, or the way I explain it to patients, it's like if you try to light something on fire with a magnifying glass, the sun shines through it, you can put your finger around other areas, but if you put it at the focal point, it'll burn you.
Right.
And that's the same concept with radiation, is we use multiple field angles to focus all the radiation on a point, and in this case it's the prostate. So the dose is hot on the prostate, and then the other tissues receive some dose, but it doesn't damage them, or they're able to repair it. The radiation, it's almost the same thing as getting a sunburn.
Right.
So we deliver the treatments over multiple days, and so usually the patients come in, they're expecting to, be radioactive or have some kind of symptom from the treatment, but they really don't. It's very similar to getting like a CT scan or a chest X-ray. You just lay there, the radiation passes through you, you get up and you go home.
Right.
And over the course of time, after you receive multiple treatments, you start noticing the side effects, and they're all inflammatory. So it's like a sunburn, and your bladder's going to be irritated because your bladder's right above the prostate. Your rectum can get a little bit irritated. But in general, the patients tolerate these treatments extremely well.
Well, I got a little excited when I was looking at these slides, and we talked earlier that we did not speak about this last year, but the space ore, which would be slide number 3, Gracie, if you can pull that one up for us. So this is a type of gel that you were talking, again, I'm stealing thunder because I was looking and I was like, what in the world is that?
Yeah, it's
but
pretty
seriously,
cool.
what is, this is very cool actually.
So this is a device that we place prior to treatment, and so typically the way it works is I evaluate the patient, we kind of sit down together, work out what's going to be their regimen, because there's probably 6 different treatment regimens you can do for prostate cancer in the radiation realm. So we sit down, we figure out which one is going to work the best for them, depending on their prostate size, what type of prostate cancer they have, because there's different types. And so then after we've decided that, most of the patients will go on for like the planning phase. And so what I do is in my clinic, I place 3 gold markers so we can triangulate the prostate on the imager on the machine. And then I also place this device. And so this is like a water-based gel that I inject behind the prostate and the rectum, and it solidifies into almost like a flexible silicone consistency. And it stays there for 4 to 6 months, but the purpose is there's a potential space between the prostate and the rectum, and so when you inject it in there, it pushes the rectum away from the prostate. And a lot of the symptoms, especially late toxicity from the radiation, is associated with the rectum.
Right.
Just because of the proximity. The bladder's pretty tough, and it can usually take quite a bit of dose, and doesn't really, you'll have frequency while you're on treatment or something like that. But the rectum, people don't like rectal bleeding.
No, that's no fun.
So
because you think something else is happening.
Yeah, exactly.
Right.
And so that's kind of limited that, along with the different techniques that we're using, but that's kind of limited that significantly.
So I'm thinking of it kind of as a cushion and something that I think you call it an absorbent, right? So when the radiation is getting into the prostate, behind the prostate where it's getting shot, it's sort of absorbing the shock value to protect the rectum a little bit.
Yeah,
is that
that's
sort
a
of
good
what
way.
we're looking at?
The radiation passes through it. It doesn't ameliorate it or absorb it, but it pushes things away. So a cushion's a great analogy, where it's just pushing the rectum away from the prostate.
I want you to make
getting
something that
way.
actually absorbs it.
Yeah.
Because look at me, I just like, but I'll tell you what, that in and of itself is, my father, it's been 30 years, but the radiation that he was receiving 30 years ago, it did kind of mess up a lot of things in all kinds of areas. So
it's very different today than it was 30 years ago.
It's so different today. It is. And Dr. Vogelweed, I'm not ignoring you, but I just feel like since we're on, if we can go to slide number 4, because we're kind of in the same area when it comes to the space ore here, and this is just a slice from an MRI, I understand, is that correct?
Yes.
But that way people can see not just the image that we saw with the graphic, but actually seeing it here too.
Yeah, so these are different kind of viewing angles through an MRI. So the one on the right's an axial, so you can see the prostate's in front, the spacer's that white material, and then the rectum's being pushed away. And this is kind of, this is called, the one on the left is called a sagittal slice. And basically it's kind of cutting through you this way. And so you can see the bladder's on the top, the prostate's there, this patient has a large median lobe. And then behind you can see the spacers kind of just pushed all the rectum away from the prostate. So this is a pretty, what I would consider a good placement.
Yeah.
I did this one, so.
I took this one, so I put it there. So here's a question. I know you talked about earlier that radiation, there's chemotherapy, which is systemic, as you were talking about too. With prostate, it's such a small organ. What is it that is physiologically happening when radiation is hitting the prostate and that specific spot? You talked about sunburn, you talked about burning earlier, but if you can explain to the audience what it is that beam is doing.
So what it does is it penetrates your tissues and damages the DNA. And so cancer cells, all they're trying to do is grow. And they lose the ability, or most of the ability, to repair themselves before they divide. And so that's kind of the mechanism that we use to kill them. We damage their DNA, they try to divide, they can't divide because your DNA is your roadmap for your subsequent cells. And so the cells, they die. And that's in your normal cells, they don't lose that ability because they're trying to survive. They're not just trying to grow. And so they're able to repair that damage and function to some extent. But it's all about focusing the dose on the area on the tumor, and then limiting the dose to the tissue surrounding it. And so the higher dose you get, usually the better tumor control you get. And so when we use very high doses in prostate cancer, but the other tissues, they're able to kind of repair the damage, if you want to think of it that way.
I think it's the first time I've heard somebody saying that it is damaging the DNA. I mean, you're getting rid of it, you're burning it, you're trying to take it out. I mean, all the things you hear about radiation, but damaging the DNA, that's a big thing. Dr. Vogelweed, I'm going to come back to you now with, we're going to talk about brachytherapy in a little while, and then oligometastatic.
Oligometastatic disease.
Yeah, that one. But first, what I'd like to do is talk about the diagnosis process. So we were talking about PSAs and PSA numbers, and let's just take a case study that there's someone who has a PSA of 7. And so you call them back to the office, and what do they do now, and how is the diagnosis done from there?
Generally speaking, well, if the PSA of 7 and they can have a normal prostate on rectal examination, you could, if I had a patient that had a PSA of 7, I would go ahead and do biopsies.
Okay.
Okay. One of the things that we've learned in the last 10 years or so is that sometimes you can miss the prostate, and we have additional you can miss the tumor inside of the prostate, and there's additional testing like magnetic resonance imaging that can help you identify a focus of cancer. But most of the time, the first thing we do is we do what we call, I forget the exact term, but it's you do a series of 12 biopsies.
Okay.
And you try to do it in specific areas of the prostate. In other words, lateral, medial, higher, and lower. And
So the idea is with the needle, you're going into all these different areas of the prostate, and hopes is the wrong word, but the goal is to find if there is a cancer in there.
In a significant amount of patients, you can find it, but you can miss it too. And even if you do magnetic resonance imaging, you can miss it. But we have these tools that do help us, okay? And unfortunately, a lot of those tools depend on the reader. It has to be somebody that's pretty good at reading them. He's pretty good at reading them. And sometimes, if you have somebody that's good at reading MRIs and they can detect the focus, and then you can biopsy that focus, even if you've done previous biopsies that have been negative. When do you do that? Well, let's just say you have somebody has a PSA of 4, you do the biopsies, they come back negative, and you follow the PSAs. Or now it's even invoked to do an MRI before you even do biopsies. But again, you have to have somebody that can read them.
Now, I apologize, I feel like I should know this. I've had stereotactic biopsies on my breast before, and that is where the sonogram is helping direct the needle to the right places. Is there anything that is similar to that with prostate cancer? Is it, or just in general, I don't know if the organ lends itself to that?
There's something that's called, well, there are a whole bunch of techniques, but there's something that's called fusion biopsy.
Okay.
Where you actually do the MRI, and then, with computers, you can compare that with an ultrasound, and you can overlap them and use a template.
I see.
And then using that template, you can hit the focus of cancer that's been identified previously by MRI.
Okay.
Another technique is just using the MRI itself to identify the focus and doing it while you're actively doing an MRI.
And then here's that next question. You have some tissue now from the biopsy, and that's always the big question. Where does the tissue get sent? How do we know if it is cancer, is it not cancer? And then we go into Gleason scores, and we go into all of this other stuff. And that's where I feel like I'm throwing the entire gamut your way. But that's where, again, that's where diagnosis comes in. It shows, you can find out how aggressive the cancer is, et cetera. So maybe throw a case study out there that you can think of that, oh my gosh, this guy seemed to be doing fine, but boom, he's got all kinds of issues going on.
Well, you go back to what you said before. Most of the time, hopefully, you catch the cancer or detect the cancer before they have any kind of symptoms. Generally speaking, if you have symptoms from prostate cancer, it's too late to cure.
Right.
But you can still treat it. But if you have the patient, you do the biopsy is sent to a pathologist. And the pathologist looks at the prostate. He'll usually, if you take cores of the prostate with your biopsies, and they'll look at a core and they'll say, well, this core has so much cancer in it. And there's a lot of controversy on how they read that too. But let's just say 50% of the core has cancer in it. Okay, so that, and then so how much of the core has cancer? Number one. Number two, how many cores have cancer? Number three, how bad is that cancer? That's where you get into the Gleason score.
Okay.
And the Gleason score basically is, to put it in a simple way, is let's just say that you have this core, and if you say the core is this pencil or this pen, and this part has cancer and this part has cancer. Well, they look at this, and as you notice, there's more black here than there is here.
Right.
Well, they look at these two, and they'll give them a score, a Gleason score. Let's just say this one's a 3 and this one's a 4. So this would be a Gleason score either 3 plus 4 or 4 plus 3.
Interesting.
And how do you know which one to use? Well,
Right.
which one is more? If you have more 4, then it's a 4 plus 3. If you have more 3, then it's a 3 plus 4.
Huh.
Is that important? Yes. It's important on how patient prognosis and determining how you're going to treat it and how,
Right.
what assistance you can use in treating it. Then they came back and they started going into grade groups, grade group 1 through grade group 5.
Grade
Group.
groups.
GG.
Okay.
And it's basically using the same Gleason score, but grade group 1 is a Gleason score of 6. Gleason score goes from 6 to 10,
Okay.
where 6 is the best, and a lot of people think that 6 is not even a cancer, up to Gleason 10. It doesn't mean, and we have tests that we can do even to help you with that, to make it in your decision making. But generally speaking, if you have a Gleason score of 6, you can do what we call active surveillance. You don't necessarily, and I'm not going to go into more details because it just becomes more complicated.
Right.
But if you have a Gleason 6, you may never progress. It's possible, but you may never progress. Or you can go 10 years without treatment, and if you go 10 years, well, you can still have an active sex life for another 10 years.
But this person should every year make sure they go and get checked.
At
tested.
least every year.
At least every
At
year.
least
if not
every year.
Twice a year. Okay.
As far as I'm concerned, it should be twice a year.
Okay.
Then you get the Gleason 3 plus 4s and 4 plus 3s. Well, it has been proven that the 4 plus 3s do worse than the 3 plus 4s. So that's why the Gleason 3 plus 4 is a grade group 2, and a Gleason 4 plus 3 is a grade group 3. Then you have the Gleason grade group 4 is Gleason 4 plus 4, and then you have 4 plus 5 and 5 plus 5.
Dear gosh. Okay. So let's take this to, now we're looking at when we do or do not do surgery, just the different options of treatments, because there's surgery, there is radiation, obviously, there's not necessarily always chemotherapy, but sometimes if there's metastasis in the way, but there's hormones, there's rice implants, there's all kinds of stuff. I keep calling it that. I know it's not rice implants, but it's like the size of the rice. That's how I remember it. But in general, I feel like prostate cancer has always been that one where you discuss it with everyone in your family. You talk to your doctor, you talk to another doctor, and there's so many options for treatments. So,
And
radiation
controversy.
boy, you're just gonna have to wait a little while because radiation is definitely one. So I want to talk about all the stuff that's not radiation yet, and let's talk about number one: when is surgery an option? And I know that's a decision with the patient and family, etc.
Yes.
When and how are hormones an option? When and how are other treatments options?
Okay, hormones are for advanced disease, except when you have patients that have a higher Gleason score and you're treating with radiation. We'll let him get into that. But age is important. Generally speaking, if you're a 70-year, 70 is more or less the cutoff because the average age that a male lives to be is 77, 78. But again, we get back to what I said earlier. If you are a very healthy 75-year-old and you think they're going to live more than 10 years, you may want to consider doing surgery. I'm not suggesting that that's what should be done.
Right.
Although I believe I can cure everything with surgery and he believes you can cure everything with
Absolutely,
radiation.
that's what we have both on.
But age is an important factor. And the
Right.
other thing is, how much cancer, the ideal cancer or the L is a Gleason 3 plus 4 for surgery. That's the
Okay.
ideal one.
All right.
Because that's the one that you're most likely to cure. But you can, you can treat the other ones. You can do the grade group 3s, the 4s, and 5s, and we get into a little bit of controversy and debate because the radiation oncologists say that, you probably, at least these 4s and 5s, you probably should not operate on. You should probably treat with radiation. And there's evidence of that. On the other hand, your surgeons are going to say, no, well, we're going to take that prostate out and then he can get the radiation. And, there's more morbidity associated with surgery after
Right.
and then radiation.
Right.
So it's a little bit controversial. There's a little bit of discussion between radiation oncologists and urologists. But the ideal patient is a patient that doesn't have a very high PSA, does not have metastatic disease, has a Gleason score of 3 plus 4, those would be the ideal patient. Once
And
you
when
get higher,
surgery is done, is the entire prostate taken out, or are there
Yes.
times where there's sections of the prostate?
that's a good question because
Okay.
there is some emphasis on what they call localized treatment or focal treatment of the prostate. And focal treatment of the prostate can be just the focus of cancer. It can be a whole region of the prostate. It could be half of the prostate. And that's all focal with more or less variation. Or you could have, you can treat two different foci in the prostate.
And that's when we come back to destroying the DNA with radiation of what's left of the prostate? I'm just kind of throwing
No.
things
If you're
out
doing
there.
if you're doing focal treatment, what you're looking for is to preserving some of the prostate's function, not necessarily for fertility, but for sexual function. Okay, because if you use focal therapy, you don't tend to affect the nerves that go from around the prostate into the penis.
I get you.
Because
Okay.
there is a certain risk of impotence. And so focal therapy, if you have a low-grade tumor, that's not a bad option. The only problem with that option is that prostate cancer tends to be multifocal.
Right.
And you may, it does require, if you're going to do it, it does require close observation. But you may have a low-grade cancer here and a high-grade cancer here. You're not going to worry about if it's a Gleason 6.
Right.
You
And I'm
can
thinking,
just treat the side.
we're looking at the size of a golf ball. I mean, if not, walnut, golf ball, I'm not sure.
It's more the shape of a walnut, yes.
Okay.
And about the size of one.
In some
But it
people.
varies in some.
Yeah, but to me, I just feel like, gosh, it's so small, but really, I guess in this situation, it really is quite large, and you're looking at different points being affected or not.
Well, this is one of the challenges for him because, the normal size prostate is about 25 grams.
Okay.
Okay, he can get a prostate that's 150 grams.
Or 200.
Or-
I just finished treating one of those.
Okay.
Really? Dear
so-
Lord. All right. So I'm going to put you on hold for a while because it's the same discipline, but it's very different on how things work. So let's talk now about brachytherapy. Is that you?
Yep.
Okay, so I feel like that's something that was brand new a while back, but I think it's something that's used still quite a lot. Describe what it is and what, again, physiologically does that do as a treatment option?
So brachytherapy has been around for an extremely long time, a very, very long time. It's probably one of the first modalities that we use to treat tumors with radiation, just implanting radioactive pieces of metal into things to
Are those the
damage
rice
DNA.
beads I'm thinking about?
Those are the rice beads.
Those are the rice
Yeah.
beads. Okay, I just think that's the size of a piece of rice. I just remember that from years ago.
So they, in the textbooks for radiotherapy, they go about like the history sometimes about how people would just, get a radioactive piece of metal and stick it on a skin cancer and it would melt away and cause all kinds of toxicity, but the cancer would be gone. We've obviously progressed nowadays to where I actually implant catheters inside tumors, and so for prostate cancer, I'll implant catheters into the tumor, and we'll either use seeds, which are those the rice things that you're talking about, and leave those in there. They decay, they kill the cancer. Or what I actually use in my clinic is I implant catheters, and we have an afterloader that houses an iridium source. And it's like
An iridium source.
It's like a radioactive piece of rice on a string.
Okay,
And it
gotcha.
goes inside the catheter and stays there for a couple of minutes, and then it
And you
comes
have
back
the
out.
other part of the catheter outside of the body.
Yeah, and so
Okay,
it goes in
so
on a
you're-
string, and then it comes back out,
I
and
getcha.
then you go home. You're not radioactive. You don't have pieces of metal in you or anything like that.
Gotcha.
And what's nice about the afterloader is you can actually shape the dose. And so you put the seeds in, and you kind of just cross your fingers and hope they went the right way. With this, you can kind of adjust for the human error aspect of it,
Right.
and avoid the urethra, avoid the neurovascular bundle, and try to give optimize the patient. It's nice because it's a very high dose that's just focused in on the prostate, and so the surrounding tissues aren't getting much, if any
Right.
dose
Which,
from that.
again, in that area, because there's so much happening in that area of the body.
But it's a whole nother, it's like a separate, almost a separate field in radiation brachy. It's the people who like surgery and the procedures, which is what I like actually.
Right.
There's a group of these individuals, and there's brachytherapy for breast, for cervix, for lung. I mean, they do all kinds of things all over the body, but I do mostly gyne and prostate, or
Okay.
GYN.
Okay. And
prostate.
when this, the metal, the little piece of metal is inside of you, does it stay there? Does it deactivate itself
Yeah,
after
it decays
a while?
over
It
time.
decays over time.
Yeah, but it like scars in there, so it's there
Okay.
forever.
It is there forever. So it's not something you would go in, take out, and then replace.
Mm-mm.
On that note, is there a way to find out, like, what test would you take to see, okay, this really is killing the tumor, this really is doing its job? How does one go through, like, a month later, we're going to check this out and see what's happening?
So great question. So basically, once we're done with the treatments, we start monitoring the patient's PSA.
Okay.
And it ends up being a tumor marker. And so patient comes in, you treat them, their PSA was 14. A lot of times they'll see them back in 3 months and their PSA is now 6 or 2, depending on what therapy was delivered.
Okay.
There's gentle therapies for patients who have very large prostates. Usually it's called fractionate, but we space those out over the course of 1 or 2 months. Patients with smaller prostates or younger, have good urinary function, we do the brachytherapy or a technique called SBRT, where we do very high ablative doses to the prostate.
Okay.
And there's a whole wide range of treatments, but the trick is kind of figuring out, who's going to benefit the most from this, because there's going to be a trade-off. You're going to have a lot of convenience if you only have to come 1 to 5 times, but you could have a lot of toxicity, or you can, come for 1 or 2 months every day, and your toxicity is going to be much less, but it's going to be extremely inconvenient. And so kind of matching.
I would lean toward number 2. Yeah, go for a couple of months and get things. So here's my question to you too, and I know we talked earlier about enlarged prostates. Prostate cancer does not mean that the prostate is larger. However, you were just saying that you were dealing with a prostate that's like 3 times or 4 times the size that it should be. Was that because of the cancer? Was that a little bit of both? This gentleman had, and again, no names, no nothing, but just out of curiosity, was this prostate enlarged because of the cancer? He had an enlarged prostate anyway, and then, oh, by the way, he also has cancer.
Yeah, I would say most men that are like, 50 or 60 or over, their prostate's becoming enlarged. It's honestly pretty rare that I have a patient that has a normal sized prostate. Most of the men I treat are in their 70s.
Okay.
But the cancer, if the prostate is big because of your cancer, it's a big problem, and you're going to know about it pretty quickly. But the patients who just have BPH, just enlarged prostate, they it's very common.
Right.
It's extremely common. But it is very uncommon for me to be treating like a grapefruit-sized prostate.
Yeah.
It's usually like a lemon or lime.
Quite uncomfortable, I'd
like
imagine.
a lemon, yeah. Well, honestly, a lot of patients, it's like shocking. They don't really have any symptoms.
And I guess if it grows over time too, it's just the way your body feels, and it's just that way.
They're like, oh yeah, my doctor told me I had a big prostate. I'm like, okay.
Okay, fine with me. If you're urinating, fine. Yes, Dr. Vogelweed?
Just one quick thing on PSAs. PSAs is not an exact test. Just
No,
because you
it's
have,
not.
if
I'm
you
glad
have,
you're saying that,
if
yes.
if you have a high PSA, doesn't mean that you have cancer.
Right.
It means you could have cancer. And there are other things. An enlarged prostate can cause, you can have a 100-gram prostate and have a PSA of 4 or 5 or 6. Or you can have an inflammatory procedure. I mean, you may have an acute prostatitis or even a urinary tract infection can cause the PSA to go up. So yes, you should check the PSAs, but you shouldn't think that just because you have a high PSA, you're going to have cancer. On the other hand, it's a very good test for people that are being treated or have been treated for prostate cancer, because then it does give you an idea of how well you're responding to the treatment.
So the fluctuation lets you know if things are...
And, but even so, there are treatments, just to make it more complicated, there are treatments that prolong survival, such as a treatment that he does that's called radium-223 or Xofigo. And there's also a treatment, immunotherapy, that prolongs survival.
Immunotherapy, that's like a whole nother show, but yeah, that's a lot. There is, because I really feel like we should do a show just on that, but I know there's so many cancers that are involved with that. It's not that we're running out of time, but I do want to cover metastasis.
Can I just quickly
yes, please.
circle
Yes.
back around?
Yes.
So I think just for people who are watching this and they're going to see their physician, I think most physicians are looking towards active surveillance for patients with low risk.
Right.
And I think it's very important to understand that, having a random biopsy and a low PSA doesn't mean that you don't have a higher risk cancer inside your prostate. And so I think the way the field's moving now is what Dr. Vogel was explaining is we're getting MRIs, we're doing other molecular testing on the tumor itself to make sure it's safe for active surveillance. And so I've actually personally gotten really into the biopsies because it's, for me, I'm usually putting needles inside the prostate, so it's pretty easy for me to do a biopsy. And most of the way physicians think is, if you're going to order a test, is this test going to change your management of that patient?
Exactly.
And
right.
And the biopsy is that kind of situation. So if you have a low-risk prostate cancer, but on your MRI you have a lesion that is suspicious or concerning that probably was not sampled when you got your prostate biopsy previously, I think it's becoming evident that it's extremely important to make sure that that gets sampled because one, it determines whether or not you get treatment, and two, it actually might change the treatment that you receive.
That's the key
So
right
it's,
there, right?
It's,
It
it's
might
very
change
important.
the treatment that you're receiving.
So I think that's kind of the way the field's moving now, and we're starting to evolve that in our practice as well. But I think it's just important for patients to understand that, so they don't think we're just biopsy happy.
But you have to be careful because it's when I said generally speaking, if you have a Gleason 6 patient, he may go a long time or may go the rest of his life without treatment.
Right.
But going back to what Dr. Mendel said, if you may have a small focus. So what that means is if you have somebody on active surveillance, that's why it's called active surveillance. And they do need relatively close follow-up depending on the situation because it may change. Okay, you may go and biopsy a prostate and find a small focus, nothing else, do an MRI, do whatever, and your PSA doesn't change for 4 years.
Right.
Okay, so you got away with 4 years. But what if you did the biopsies, had a very small little focus, his PSA was 4.5, you can order an MRI with the hope that it gives you additional information, but even if the MRI is negative, you're still going to monitor that patient. You're still going to check his semen 6 months, recheck his prostate, recheck his PSA, because those are the clues. And that's why it becomes a little bit more complicated, and that's why we do it, because we have to keep an eye on these patients. And some of them don't listen, and they think they're home free.
Yeah, active surveillance, they just hear surveillance. On that note, and when I say active surveillance, and when we're looking at age groups, so you said earlier that there is a medical school of thought that says, no, we're not going to do screenings anymore. And now I'm just asking Dr. Vogelweed, and I'm asking Dr. Mendel. So I'm not asking about whoever's saying yes or no out there. What would you suggest a normal, healthy male, when should they have their first prostate cancer screening?
When they turn 50, as long as there's no family history, or African American males should be screened at an earlier age,
And
just
for the
because
most
they
part,
have
they
higher.
Yeah. And they don't have to come to you. It would be nice if they came to you, but primary physician, again, the easiest way to do it is just to wrap it in, check off PSA level on the blood worksheet that you're doing, and tell me, yes.
Do a rectal exam.
Okay.
And if those family practitioners, primary care physicians, don't know how to do a rectal exam, they should learn how to do it. They should get it done in their training, because those patients don't have to come to see a urologist.
Right.
It's only the ones that have abnormal tests, because you can also have a normal PSA and have an abnormal rectal exam. And in that situation, you could still have a cancer with a normal PSA.
Right.
So it is important to do the rectal exam, and it is important to do.
And if your doctor doesn't do it, ask for one. And the reason I'm saying this, we were joking, not joking, we were just talking before this program. I'm from the other side of the world, so I'm from Germany, and I was talking about what program I was going to be doing when we come back, and that is part of the annual exam anyway. Males, females, they have a digital rectal exam anyway. For females, it's a different reason. For men, obviously, we're trying to see if there's an enlarged prostate, not necessarily because of cancer, but if there happens to be prostate issues, urinary issues, etc. So what I'm trying to say to the audience is that if it's not already included in your annual exam, ask them to check off the PSA. It's just, I don't even think it's an extra tube of blood. It's just, and then get a digital rectal examination. It's not fun, but do it. It just helps with everything that's going on. Let's talk about metastasis, because we haven't really talked about systemic therapy. We haven't talked about chemotherapy. Both of you guys are laughing. Why?
Oh,
Because he can cure everything with radiation.
Oh, because
No, but he'll tell you about oligometastatic disease.
Well, there was a point that was talked about earlier. By the time somebody has symptoms, chances are they're very advanced in disease, and maybe there has already been some spreading. So metastasis is just spreading. Let's just talk about any case study, and Dr. Mendel, I'm just going to start with you, radiation guy who can cure everything. So now, prostate cancer would first spread where, usually? And I know it's different, but usually it would spread to?
So usually patients with metastatic disease, it's going to be in the bones. But in general, in tumors in general, you have lymphatic spread as well. But for whatever reason, prostate cancer really likes to go to the bones.
Great.
And so, essentially in the metastatic sphere, there's been, the old way of thinking was it spreads to your bones, you get hormone therapy, and that's it. And now there's been a huge advancement in medical therapies and then also radiation techniques to kind of help these patients that have metastatic disease. We're able to, usually not cure them, but at least prolong the durability of medications they're on. And so the role for radiation is if patients have bony metastasis and it's causing pain, we can palliate that pain with radiation, and it works very well. It can, if patients on narcotics or anything like that for that pain, 70% of the time you can get them off of that.
And we're talking about bone right around the prostate, or are we talking about bone
usually it's the
everywhere?
spine, actually.
Usually
it's usually the spine. Yeah.
Axial skeleton.
Yeah. So you'll get disease there. It's painful. You can radiate that. But what Dr. Vogelweed is talking about is there's now a new space called oligometastatic, meaning you have
Say that slow.
Oligometastatic.
Oh, that's what I have written here. Oligometastatic. Yep. Okay.
So that means you have few bony metastases. And usually I say less than 5.
Okay.
Because I have 5 fingers.
Ah.
But basically, you can treat those metastases wherever they may be. And hopefully, the goal is hopefully to cure the patient, but in reality, that's very low. But it does actually help prolong their survival, and it's been shown in multiple trials, and actually, it's been shown in other disease sites as well.
So again, we're looking at, and I'm going back to what you said earlier, if we're looking at radiating the areas that the cancer has spread to the bone, you're looking at messing up the DNA of that cancer, so that either it stops spreading, not necessarily disappears, but is that the idea? Because I know once it goes to the bones, it's hard, and I respect that. The word cure is a scary word to throw out there. So when you're looking at these, you're saying 5 sites, let's just say 6, 7, 8 sites. Is that what you're doing? You're targeting as you are the prostate, you're getting as targeted there as well?
Yeah, so with these new techniques, with we call them stereotactic techniques. Basically, you're treating just what you see. In the prostate, a lot of times you have to account for motion or the patient breathing or just these kind of things. But when you're doing the stereotactic techniques, the motion management is much more precise, and then your treatment delivery is much more precise. And so you can deliver these ablative doses to the tumors. And the way I always kind of thought about it is
ablative doses, meaning you're getting rid of those areas of cancer. Okay.
Yeah. So the dose is so high that essentially nothing will survive.
You're knocking it out.
Yeah.
Okay.
And it's usually delivered over 1 to 5 treatments. So very high doses, ablative doses to just basically burn the tumor out.
Okay.
But the way I think of the oligometastatic disease is essentially you have your cancer, it started spreading in the blood, and a couple of cells made their way out and started growing somewhere, and those grew, and now you get rid of them, and the thought is, or the hope is, that there weren't too many other cells that had left the primary tumor, and we're hoping that the hormone therapy is able to take care of those microscopic cells, the chemotherapy is. And that's kind of the logic of taking out the larger tumors that have grown outside of the primary tumor and using the other therapies usually to help mop up the rest of the cells that may have snuck away, but they're trying to grow, haven't started growing yet.
So Dr. Vogelweed, because we don't talk about hormone therapy with most cancers, it's usually a male or female dominated cancer. So talk about hormone therapy in male cancer, so in this case prostate cancer. And what Dr. Mendel was talking about, if there is metastasis and hormone therapy. Why is it that hormones attack prostate cancer specifically? If we can explain that to the audience, male, female type situation.
Okay, your male hormone or testosterone doesn't attack, it feeds. Prostate cancer cells use the testosterone to grow. It's part of their growing cycle, if you want to call it that. And Huggins in I think it was 1942 made the first publication on actually removing the testicles and controlling the prostate cancer for a short period of time. And after that, we had all these other medications and treatments to block the production of male hormone. And so the first treatment for advanced disease is blocking their male hormone. But blocking their male hormone, when you do something like you either remove their testicles or you give them a shot, or now there's even a pill that you can give that stops the production of the male hormone, it probably covers about 90–95% of male hormone production.
That much?
Yes.
Really?
But your adrenal glands also make
Right.
and the male hormone. And prostate cancer cells, like cancer cells every place else, are very smart. And they're only interested in growing. And so they will become prostitutes. They will figure out a way to fight just about anything you throw at them. And so then now we have medications that actually block the entrance of testosterone into the cell at 3 different levels.
Interesting.
Okay.
Okay.
Then on top of that, we have the immunotherapies that we talked about before.
Right.
You know, the PARP inhibitors. We have, you know, you have chemotherapy that you can use, and so it just becomes more and more complicated. But the mainstay, the very first step, is to block the male hormone. Now, in addition to that, Travis can tell you how they use it. Dr. Mendel, I'm sorry.
No, we can call him Travis. He's 12 years old anyway. Look at him.
He can tell you about its use in combination with radiation therapy.
Okay. Let's do that. And I do want to give you a countdown. We're like at a 10-minute mark, just so you have in the back of your heads is something that we haven't talked about you really want to get across.
Questions
with
maybe
it.
from the
Yeah,
audience?
questions. Yeah, exactly. So, so talk about with radiation. Oh, 5 minutes. What? So talk about radiation and hormone and just your combination of working with that.
So basically, using the Gleason scores and a couple other factors, we determine whether a patient's going to be low risk, intermediate risk, or high risk. If you're high risk, we're aggressive. If you're intermediate risk, and I always tell patients that's like garden variety prostate cancer. If you're on the higher spectrum of that, we usually use hormone therapy. And then if you're low risk, a lot of times we watch those patients. And so essentially, high-risk patients get 2 years of hormone therapy. Intermediate-risk patients is plus or minus 6 months of the hormone therapy.
Okay, so when you're doing both of those, it's again, everything in the combination works that way. So we do have like a whopping 4 minutes left. So Dr. Vogelweed, and I apologize, I thought we had a little bit more. What is it that we haven't covered yet, or something that we've covered? I know. 3 more hours we can stay here, but they have other programming that comes on, you know, after us. I'm not quite sure what's running after us, but not as exciting as we are for sure.
Of course. Yeah.
But what is it that we haven't addressed yet tonight that we'd like to address?
Get checked.
Yeah, just get checked.
Get checked. Please
Exactly.
get checked. I mean, it's so important to get checked. And it's so important for our primary care physicians to check these patients, because they're the ones that pick up the cancers. They're the ones that do the testing. Not everybody goes to a urologist.
Right, exactly.
And so, yeah, it's very important. I mean, if they check these patients, it's a simple test to do. And if there's any concern, they refer them to us. You know, we will catch more cancers, and we will catch them on time.
Right. And again, 50. 50 to me is the magic age for almost anything. And I know that people that are watching tonight, you're not just males, you're not, you know, hoping you're male or female, one or the other. But at the end of the day, all the stuff that you need to check, if you haven't done it by the time you're 50, do it all when you're 50. And if you have a primary physician, even if you don't, get one or go to one and ask for all of this. If you're female, ask for a digital breast cancer exam, you know, ask for prostate cancer exam. What else is there? There's colonoscopy.
Some patients are getting lung cancer screening with low-dose CTs.
People are getting lung cancer screening?
Smokers.
Yeah, now we do that.
So that hits close to home. My mother was a smoker. She's been gone 29 years. She had small cell lung cancer. I didn't know screening was a thing for people that, okay, that's good.
It's relatively new, but
Okay.
they do low dose CT scans for patients who have like a long history of smoking.
Interesting. Okay, good to know. Sorry, you can tell I stopped on that one. So what other screenings are there that we can talk about? I know that they're not cancers, but you're looking at making sure you get your cholesterol checked, just all the heart stuff you need to do, bone density tests and it's not just for females, it's for males too, but you're nodding on that one.
Well, we use, when you treat patients with hormone manipulation, they actually tend to lose bone density in it, and it can exacerbate osteoporosis. And most patients that come in with prostate cancer are older, and they've already have some degree of bone loss just to start out with. They have increased risk of developing diabetes. They have increased risk of developing metabolic syndrome. They have increased risk of cardiovascular disease. And these are all things that we take in consideration once we start treating the patients.
So I'm going to quickly go through this because, again, we're talking to an audience that isn't in the medical field. Testosterone is something that does help with the bones. Estrogen is something like when women, girls, us, go through menopause, when they start losing estrogen, that's also a helper with bone building, correct?
Correct.
Progesterone, et cetera, only because we're not just males that are here. And I only have like a minute and a half to go through. So what I want to do really quick, unless there's something else you guys want to ask or throw out there, I want to let people know where they can watch this program again. If you missed some of what we were talking about this evening, there's several places that you can catch the show again. One of them is at pbselpaso.org, and just look for programs, go to the El Paso Physician, and you'll find us there. Also on the El Paso County Medical Society website. That website is EPMS, just think of El Paso Medical Society. That one's a .com, and so you can find that one there. And also, if you go to YouTube, you can look up the El Paso Physician. You can also look up PBS El Paso and then El Paso Physician. You can find it there. I want to say thank you so much to Mustafa, who has been manning our phones this evening. I know it's kind of crazy. We are a medical show. You did wave. Nice to see you. We are a medical show, so we are urging those of you that have not gotten your vaccine yet for COVID-19. We're not telling you what to do. We're just asking you to really consider it. And we would not be doing our job if we did not say that that was something that we hope that you do. This has been underwritten by the Rio Grande Urology Group, and thank you so much for being here. We also want to say thank you again to the Texas Tech Paul L. Foster School of Medicine, the El Paso County Medical Society. I'm Catherine Berg, and you have been watching the El Paso Physician.